Peter Kennerley is going to join us first in this segment of the day. Peter is a team leader in addiction treatment services with the Ministry of Health. He's responsible for improved approaches to coexisting mental health and addiction treatment. And he's worked in a number of roles in the ministry, was involved with tackling methamphetamine and action plan back in 2009, which was mentioned earlier. Would you please welcome, first of all, Peter Kennerley this morning.
Thank you, Tim. Kia ora, everyone. Good morning. Firstly, thank you for staying after Tom and Doug's presentation this morning. I'm actually thrilled that the audience has remained to listen to a couple of bureaucrats talking about planning. There have been various calls, perhaps most notably from the Law Commission and the submissions that were made as part of the legislative review process last year for a national addiction treatment strategy. However, as this slide shows, there are already a number of strategic type documents for mental health and addiction treatment services out there. Perhaps the question needs to be reframed along the lines of not is there a plan, but in fact are there too many plans, and how do we develop an integrated planning framework for addiction treatment services so that it is well understood and meaningful at all levels of the health sector and also to consumers. What the Associate Minister, Dr. Jonathan Coleman, is seeking is a more aligned approach that will bring together the work that the Ministry of Health is doing around the Service Development Plan with the work that the Mental Health Commission is doing around the blueprint model that Lynn will talk about, and the work of Workforce New Zealand around future workforce capacity and capability. I've also added on this slide two other bits at the end there, firstly about research. And I want to raise as a possible prompt for discussion with you about whether we need to develop a national research agenda for addiction treatment issues and try and identify, well, what are the big gaps in our knowledge? How do we plan not just for today, but for the future? Should part of the blueprint, when it's considering resourcing, think about resourcing research. I've also added the words data and information in here as well. Clearly, data and information are not the same things. But it raises the question, what is the information that we need to be collecting to know how well do individual services work and how well does the service, the sector as a whole system, how well is it functioning? A word that you'll hear a lot of these days is productivity. How does one service with the same amount of funding deliver more than another? How do we use outcome measures to understand what is the value that we're getting? So somewhere in our planning, I believe that we need to be including these sorts of data and information issues if we are to lift performance. The proposed Service Development Plan replaces the Mental Health and Addiction Plan 2010. It is an attempt to lay out the driving instructions for the next 3 to 5 years. The document itself will be quite high level, so there will be some flexibility around how DHBs are able to implement it. I just want to touch on an issue that Tom raised, which was around the contribution that addictions make to other health issues. And those of you who work in the DHB services will be well aware that the Minister of Health, Honourable Tony Ryle, has set out a number of health targets. And those targets are around cardiovascular disease, diabetes, reducing emergency waiting times. And I think the question must be asked, to what extent do addictions in this country contribute to those issues? And if we are to achieve those targets, should we also be tackling addictions at the same time? The next 3 slides, list the various draft service goals that are included in the draft Service Development Plan. I just want to quickly go over those without spending too much time, but they are all quite high level. How do we make something meaningful out of these various goals? So first of all, we want to have an emphasis on prevention. We want to make sure that treatment services are in the best interest of service users and their families whānau. I think we must never, ever treat consumers as some kind of abstract group who we do things for or to. And it's a strength of the addiction treatment sector that so many people in their own journey of recovery are part of the sector. And I think that's quite a unique and special feature of this sector. We need to ensure better access to effective self-care and early intervention. And we need to ensure that funded services are effective and provide value for money, a theme that was touched on by Peter Dunn. We need to ensure that people with severe mental illness and addiction problems have access to those specialist secondary services, an issue that Doug touched on. We need to ensure that service delivery options are flexible and responsive, reflecting better, sooner, more convenient, which is New Zealand's primary care strategy. We need to support people with stable, enduring conditions with good primary and community care. And that's particularly relevant for people on the opioid substitution treatment type programs. And we need to use specialist mental health and addiction service expertise more strategically, with the view to increasing capability of primary and community care. I just want to touch on an issue that David Bratt touched on too, is that we need to take a very wide definition of what is primary care. Primary care exists outside of only general practice. We should be thinking, for example, maybe possibility of midwives or school health services. How can we involve them? I might touch on that a little bit further on as well. And the third slide, we need to support and equip the addiction workforce at all levels to function efficiently and strategically. We need to respond more effectively to the needs of Māori. We need to respond more effectively to the needs of special populations. And we need to maintain the focus on recovery, including well-being and resilience. The time frame for developing the service development plan is, of course, or as always, fairly tight. We've been engaging with stakeholders over the last few months, and we want to have the analysis and synthesis of ideas that will form a new service development plan finalised in September, with something we can put before the Minister by October. In closing, I just want to flag with you again for some discussion some more issues. And the first one is this: how do our service development plans, blueprint and workforce plans for the health, are they for the health sector only? How do we include all those other sectors such as justice? And I'm pleased to see Jared here, and also Brolman from corrections, and also welfare, that not only have an interest in addiction treatment but are investing in addiction treatment themselves. How do we include that into our own planning? In terms of primary care, yes, we do need to support general practice, but we shouldn't try and impose brief interventions and all these other things on there. We need to inform, to promote, to discuss, and I guess first of all consult with the Royal College of GPs around what is the appropriate approach. The second issue is planning needs to be long term. We need to be thinking well in advance of 1 or even 3 years. At this stage, what might replace Te Tahu and Te Kokiri beyond 2015? Our planning needs to be well integrated, not just a strategy, not just an action plan, but also the resourcing, the workforce, the research, data and information. All of those elements are essential, not just parts of it. And finally, whatever the vision is, it must be relevant and understandable and known at all levels. Thank you.